Ventilating older adults and you're doing a bag valve mask, there are many changes that you need to be aware of to maintain proper ventilation. When you have a patient with altered mental status, we know that they are far more likely to occlude their airway. One of the things that we were always taught was when intubating, take out their teeth. It's much easier, and that's true. However, when using a bag valve mask, you need those teeth to maintain the proper anatomic alignment within the mouth. So leave the teeth in unless they are impeding your ability to ventilate. If you have a person where the dentures are a problem and you cannot keep the dentures in, remove the dentures, take a 4x4 that is folded up and insert it into both cheeks, which distends the lips and the airway and will make it easier to ventilate. With the older patient, as we have talked about, they lose their ability to maintain tone in the airway. Therefore, basic positioning is incredibly important. I cannot tell you how many times when I've been called to the trauma bay to assist in an airway where they say they cannot bag the patient when the solution was basic BLS maneuvers. Chin lift or jaw thrust absolutely makes all the difference in the world. We use this more than any other airway technique. It is the most basic but the most important. When you're bagging also, particularly with an older patient with COPD, you may need to use higher intake pressures but allow for adequate exhalation. You may ventilate at a lower level. We get all excited, I'm in this boat, and we want to crank the bag and hard and fast, but take your time. Slower is better. Give them the chance to exhale and listen and find out, are you having stacked breaths? Are you trapping air within the lung? Because older people are far more prone to, as we would say, blowing out a lung, getting intention pneumothorax, which is a life-threatening situation. So be very careful with your pressures. The other thing, something we don't normally think about, is if you have the ability to adjust the amount of air in the cuff of the mask that you're using, use that. In one study, they found that of patients they were having difficulty with bagging, 50% were due to a wrong pressure within the mask. So see if you've gotten a good feel. Make sure that the mask is properly placed and that it is properly sized. I can't tell you how many times I've seen a nurse run up with a pediatric mask for an adult patient, and it's no surprise when you cannot ventilate that type of patient. And always remember, with the mask, it's better to go larger than it is smaller. The mask needs to completely go around the entire mouth so that you do not have an air leak.
When it comes to managing the airway in an older adult, one thing to keep in mind is, what are the patient's wishes? Do they have any advanced directives filled out? Do they have a MOLST form? Do they have a living will? Do they have a do not resuscitate order? So you want to make sure you know that status before you get into the situation of then, okay, I may have to do some advanced airway. Even if they have an advanced directive, it's usually not a do not treat, but a do not resuscitate. So if the person is in respiratory failure, we still have to treat that respiratory failure. It only comes into effect when they go into respiratory arrest. So we would track breathe for them, or we would intubate for them if it's appropriate. They don't have a written order against it. Remember the fact that once they are intubated and put on a ventilator, it's going to be difficult to wean them. So we don't want to get there unless that's the difference between saving their life or having them die. So once we make that decision that they truly are in respiratory failure and we need to manage their airway, then we begin to go about it with all the tools we have in our tool belt. So the CPAP, the advanced airways, and intubation.
Pre-hospital care providers need to be far more aggressive in airway management when working with an older adult. As we've already talked about, they lose their reserve much more quickly and have less ability to maintain their airway for a number of reasons. Therefore, several things need to be looked at in the older patient. As we talked about before, are they getting tired? But more importantly, what is the status of their level of consciousness. One of the first things that we will see when an older patient is about to lose their airway is that they will either become very anxious or more likely they will become less responsive. When you start to see a patient become less responsive or a paradoxical decrease in their respiratory rate when you would normally expect them to be tachypnic, you need to be thinking about intubation or using some type of airway adjunct. Other things to watch very closely are the SpO2, the amount of oxygen in their blood. As we talked about before, older patients have a less reserve and at a lower level will have less time before they start to go into shock and severe acidosis, and so you need to be far more aggressive with intubation in that circumstance. Other things that you will see more often in an older adult, such as sepsis, where you may need higher levels of oxygen and be offloading CO2 more likely, are again far more common in the older patient, and we know that any older patient that has an altered metastatus, sepsis is in the differential. So you need to be far more aggressive in managing the airway, both from a BLS as well as an ALS or intubation standpoint. Moving on along that line, there are special considerations when placing a nasopharyngeal airway or an oropharyngeal airway, and as well as intubating the older adult. When you get older, the skin, the mucous membranes of the nose and mouth and oropharynx change. You become much, much more prone to bleeding. So excessive manipulation of the airway can lead to a disaster, both from a non-invasive and an invasive standpoint. When placing a nasopharyngeal airway, it is even more important in an older adult to try and fit the nasopharyngeal airway to the patient. If you're having trouble placing the airway, and make sure you use as much lubricant as you need, try the other nostril. Usually it's the dominant nostril, the right side, that's larger, but not always. Oropharyngeal airways are even more of a challenge because of the bleeding risk. If you insert them backwards and you scrape the top of the hard and soft palate, you can increase their risk of bleeding and the amount of swelling, making it again a crash airway and losing the airway. So be very careful. Always use a jaw thrust or chin lift maneuver when you're placing the oropharyngeal airway to maintain tone of the tongue so that you don't get the tongue caught between the posterior oropharynx and the oropharyngeal airway. When intubating, it is clear that we need the best intubating conditions that you can. Therefore, in the sickest patients where you have the least amount of time to get the tube in, you need to have the best intubating conditions. Consider RSI. It's a great program. The people are very well trained. It is important that you give the right medications at the right time, and we're always working on getting better medications for the pre-hospital care people. I just had a meeting with Jeremy Cushman a while ago looking at this to get the best intubating conditions, because you will need less attempts and be far more successful when the patient is properly prepped. This includes such basic things that we forget, like positioning. Make sure you have another person, a BLS person, to be able to maintain the sniffing position and to be able to maintain pressure, the burp technique and Selig's maneuver, because those can increase your ability to intubate by 1 full grade, which is very, very significant. So the combination of a good helper being able to maintain the proper positioning of the airway with the right medications to prep the patient properly and an experienced intubator is your best chance for getting a definitive airway and saving that patient.